Thank you for that really illustrious opening, and I think it was directly copied from the hospital website, so that is why it is blown out of proportion. So I'm so happy to be here and talk about pulmonary, occupational hazards, and I'll try to finish it in 10 minutes. Right. So any occupational disease, sir has very vehemently and very nicely told us, is a disease that is contracted primarily because of result to, when you're exposed to something at your workplace. And work-related diseases can have multiple causes. It can be, just due to the work, or there can be multiple factors which play in tandem and which can actually make work-related stress or work-related disease out of proportion. So when you talk about occupational lung disease is a major killer. Occupational lung disease is one of the most important, most frequent, lung disorders that we see in our OPDs, and very often during our busy OPDs, we actually forget to ask about their occupation, and this is something which is so commonly seen in our OPDs and very often missed. So if you look at the statistics there, they're extremely alarming. 2 million of the world's 2.5 billion workers die each year from occupational accidents or diseases. I absolutely agree with sir. People were crying hoarse about COVID and so many deaths, but this is something that has been there for years together. And majority of the 2 million people who die due to their occupational related diseases would have some kind of a, respiratory disorder. The most important respiratory disorders which actually kill a patient would be interstitial lung diseases and lung cancer. However, the most important respiratory diseases which arise out of occupational hazards are obstructive airways diseases, which are responsible for majority of the morbidity that we see in our OPDs. So when you look at the occupational lung diseases, they can be acute inhalational injuries. They can be something known as occupational asthma, which is something that we see very, very commonly. Most of us talk about occupation-related interstitial lung diseases, the fancy pneumoconiosis, asbestosis, silicosis, and hypersensitivity pneumonitis. However, in clinical practice, occupational asthma is much more common than these pneumoconiosis, occupational infections, lung cancer, and variety of pleural diseases, and all these can be attributed to workplace exposure. The most important occupational disease that we see in our OPDs and clinical practice is actually occupational asthma. Up to a quarter of all patients with asthma, 1 out of 4 patients who you treat in your respiratory OPD with asthma would actually have an occupational asthma, which is either a work exacerbated asthma, which means that the patient had an asthma, but now due to the work environment, the asthma has got exacerbated, or it can be a true occupational asthma, which means that the asthma has started due to the work environment. So the work environment can either exacerbate a person's asthma or can actually start the asthma for a person. There are 2 kinds of stimuli which can lead to work-related asthma. One is an immunological status and the other is a non-immunological stimulus. What is an immunological stimulus? An immunological stimulus would be seen in someone who is exposed to a high molecular weight antigen. Someone who works with enzymes, someone who works within the cattle industry, someone who works with animals, someone who works with detergents. The molecular particle size of these antigens is extremely large. What is very important to note here is the latency period. So patient may have worked in the industry for 10 years and then all of a sudden the patient may develop an asthma, and we would not attribute it to their work because we would think that the patient has been in this work for the last 10 years. Why has he developed asthma now? So this period of latency is extremely common in people who have exposure to an immunological stimulus. This immunological stimulus is usually a high molecular weight substance. So always go back to the occupational history of the patient whenever you are working up an asthmatic in your OPD. On the other hand, you have something known as a non-immunological stimulus, which is something very common, which comes to our minds. And very often, if a patient tells you that they work in an industry where there is chemical exposure, someone who works in a printing press, someone who works with chemicals, it would immediately strike your mind. These are classically low molecular weight antigens, and they would cause a rapid asthma or they would cause an early asthma. So you would pick them up in your OPD. However, the high molecular weight asthma, which is far more frequent than the non-immunological or the low molecular weight asthma, is often missed out by us because we don't ask for that history. When should you suspect occupational asthma? The golden rule: suspect it in everyone. Every quarter of your patients, every 1/4, 1 out of 4 patients is going to have an occupational asthma, and take their history. If it gets worse during their occupational days, if it gets worse during the weekdays and it improves on the weekends, If it improves on a holiday, then obviously the patient has a work-related or a work-exacerbated asthma. A very nice graph which is showing you the peak expiratory flow rate measurements of the patient and the variation. Now look at the first part of the graph. This is when the patient is going to the office for the first 5 days of the week. And look at the peak flow variability which has settled down in the last 2 days of the week when the patient is at home. So this is something that we do practically. Whenever we have a patient where the patient has an asthma, there is no obvious family history and we are not very sure as to what has caused the asthma, we ask the patient to do a peak flow charting at home. And if the patient comes to you with this kind of a graph where on Monday to Friday, the peak expiratory flow rate is as high, as low as 200, 300, and on the weekend, it goes up to 500, 600, probably you are dealing with a work-related asthma. How do you manage this? Obviously, the management which is pharmacological is the same. So there is no difference in the pharmacological management. You will obviously give them inhaled steroids, you are going to give them bronchodilators. But what is most important is prevention of the occupational exposure. And this is something which is very hard. Now, telling someone to change their job, someone who works as a menial labor, someone who doesn't earn very much, someone whose livelihood is dependent on their job, asking them to change their job, well, it is something not very practical. And most of the time, we all know that staying away from that antigen would be the most important treatment of their asthma. But certainly, it is not possible at all times. So we'll talk about the filters, the respirators, once we talk about the pneumoconiosis, because that is something that is going to help them. Also, delay in diagnosis. Now, asthma, as it becomes more brittle, as it becomes more chronic, it leads to a progressive decline in lung function. The problem is if you don't pick up the antigen that is causing the asthma and the patient has a persistent asthma, the patient is going to have a progressive decline in the lung function. So it is very, very important to take the occupational history. It is very important to ask about the patient about an exposure which is there and try to remove that exposure, because otherwise the patient is going to have persistent airflow limitation, and after 10 years the patient who had asthma is going to behave like a patient who has COPD. So the variable airway obstruction, which is so classically seen in asthma, becomes fixed, and that occupational asthma becomes an occupational COPD. Pneumoconiosis is something which is very, very fancy, and all of us as medical students have talked about this. This is an important long question, but a lot of us who don't work in the respiratory medicine don't actually see this. However, pneumoconiosis is something which is extremely common. It is due to the deposition of dust particles, whatever is the dust particle, depending on the type of the dust particle. It leads to progressive fibrosis of the lungs, and the changes that the dust or whatever inciting agent is causing in the lung, the whole plethora of that is known as pneumoconiosis. Lots of industry in India is associated with pneumoconiosis, silicosis, multiple industries including slate pencil workers, polishing industries, stone quarries, which are extremely common in our part of the world, potteries, stone crushing, all of them can cause silicosis. Coal workers pneumoconiosis is something extremely common, people who hail from the miners area. And all kinds of coal worker associated disease, coal associated disease can be seen in these patients. Asbestosis is something very, very common, and one of the most common causes of pleural malignancies that we see in our practice. And whenever you even take the history, these patients would not really give you a forthcoming history of having worked very near to asbestos. And also, they would give you a very strange history that it is so very common in females in our country, wherein the female is a homemaker, she's a housewife, and the female has been washing the clothes of the husband who was working in some kind of an industry where they were exposed to asbestos. So very, very difficult to take this kind of history in our country, but asbestosis, especially pleural asbestosis and mesotheliomas, are something which are so common in our country, and almost every month in our practice we would see one case of mesothelioma. Now if you go by that standard text, the rates of these diseases are exceedingly low. However, in India, these diseases are still exceedingly common, and you would encounter them very regularly in your clinical practice. So pneumoconiosis has been classified this way. The complicated pneumoconiosis is the one which leads to fibrosis of the lungs. So coal workers pneumoconiosis, silicosis and asbestosis. These three can cause permanent fibrosis. So all these three are called as complicated pneumoconiosis. Uncomplicated pneumoconiosis do not cause fibrosis. They do cause lung dysfunction, but they will not lead to permanent damage to the lungs. And this is berylliosis, aluminiosis and talcosis, and these again are very commonly reported. We just don't think about them. Berylliosis presents exactly as sarcoidosis. There is no clinical distinguishing factors. You do the CT scans of these patients, you would see mediastinal lymph nodes. 99% of these patients are going to get treated as sarcoidosis with steroids, and the patients will have no effect whatsoever, and someone would label them as refractory sarcoidosis. So if your patient of so-called sarcoidosis is not improving, please think about berylliosis and go back and take the occupational history. And then there is something known as mimics of pneumoconiosis, wherein there is no, actual fibrosis. There is some amount of retention of the material in the lungs, but it doesn't lead to fibrosis, and that is seen in siderosis and stenosis. Silicosis is extremely common. There are multiple forms. The amorphous form, the vitreous silica, which is diatomite, is a naturally occurring substance. It is relatively non-toxic. The inhaled crystalline silica, which is the quartz or the cristobalite, is extremely common and is the one which is associated with pulmonary diseases. So another thing, silicosis can be either acute or chronic. In India, acute silicosis happens when you are exposed to high levels of silica. Chronic silicosis happens when you are exposed to you're exposed to silica for a long period of time. What is more important in India is the relation of silica to tuberculosis. Silica particles decrease the macrophage activity of the pulmonary alveolar macrophages and are a leading cause of pulmonary tuberculosis. So patients with silicosis most of the times die due to tuberculosis rather than true silicosis itself. Coal workers pneumoconiosis again is a very common disease in our country. Majority of these patients will have an obstructive airways disease. So 80% of patients who work in the coal factories are going to have an obstructive pattern on their PFT. If they're very unlucky, if they have been exposed to very large quanta of coal dust, they are going to develop lung cancer and pneumoconiosis. Pneumoconiosis, thankfully, again, in majority of these patients is going to be simple coal workers pneumoconiosis, when it does not lead to fibrosis. However, in the unfortunate few where the quantum has been extremely high, or if the patient is genetically susceptible, the patient is going to develop progressive massive fibrosis. So again, the spectrum of coal-related lung disease in India is extremely wide. Majority of these people, thankfully, suffer only from obstructive airways diseases. However, a lot of them, what these curves are trying to tell you is observation over years. As the patient is exposed more and more to coal dust, over a period of time, fibrosis sets in. And if the duration of exposure is very high, the patient is going to develop progressive massive fibrosis. So, complicated coal workers pneumoconiosis, you see these absolutely large plaques, and PMF is something which is like a death sentence. So if a patient develops this, the patient, the only treatment option left is a lung transplant, which again is not really feasible in our country. Asbestosis is again very common. It leads to asbestos exposure, can lead to asbestosis. Pleural diseases are very, very common due to asbestos, because asbestos classically tends to accumulate in the pleura. It has a predilection to deposit in the fibrous tissue and therein lead to the chronic inflammation that asbestos leads to malignancy. So benign pleural effusions are very, very common with asbestos. Pleural plaques, again, most of these would develop in people who have been exposed to asbestos for a long period of time. Pleural thickening, parenchymal fibrosis would happen in up to 5 to 7% of patients who have been exposed to asbestos. Thankfully, most of them are again benign diseases. The problem with asbestosis is when it develops this kind of a CT scan, which is known as a UIP pattern or a usual interstitial pneumonia kind of a pattern. This is when the patient is going to land up in respiratory failure. And of course, the problem of mesothelioma is always there, and patients who develop mesothelioma are going to actually have very poor prognosis and are going to develop malignancy. The chances of a patient developing lung malignancy with asbestos is actually much higher than that compared to tobacco. So this is something, again, in patients who have a history of lung cancer and you're evaluating them, please don't forget to take the history of asbestosis. Think beyond cigarette smoking, think beyond tobacco in these patients. So imaging of patients who have suspected pneumoconiosis. The classical chest X-ray is recommended. However, it is a very insensitive tool. It is only going to show you changes when the lung disease has become really advanced. However, it is an inexpensive tool. It is something that is available. And unfortunately, most of the laws as of now still talk about only X-rays, and these X-rays should be interpreted as the ILO, there's a classification system of this. People who are interested can go back and look into this. There's a certain way in which you are supposed to interpret. However, much more superior than radiology is the testing of lung function tests in these patients. So simple spirometry is actually going to give you a lot of data which is much more forthcoming and much more valuable than what a simple chest X-ray or an ILO X-ray is going to tell you. So apart from a radiology, a chest X-ray, because CT scans are obviously not possible for everyone, it is an absolute must that any patient who has an occupational disorder or an occupational related lung disease or any lung disease in general should undergo a lung function testing. Treatment of pneumoconiosis unfortunately is extremely difficult. Supportive therapy, the patient needs to stop smoking and obviously you need to stop the exposure. The problem is most of these people come to us when they're already in respiratory failure and the only option left is a lung transplant, which is only available at a few centers in India, nowhere in the government setup, and in the private setup it is a hefty amount, 60 lakhs to 1 CR, and majority of our patients would not be able to afford it. So prevention is the key here, and this is the last slide wherein you talk about the PPEs or the personal protective equipments which are available. So there are two kinds. One is the kind wherein there is a breathing apparatus which is actively supplying clean air, fresh air to the patient. The other one is just a purifier wherein no active air is being given to a patient, and the patient is actually, it is just acting as a filter, and the more superior the filter, the better is going to be the protection for the patient. However, the best way of protecting these patients is with a breathing apparatus, especially the ones who are exposed to very high levels of coal dust or silica. These patients, unfortunately, if you look at the real situation in our country, most of these people would be working even without a simple surgical mask. So that is a very sad situation. And when you talk about the protective value of these patients, you know, we've all, due to COVID, we've become very intelligent about N95, N97, N99. When we talk about PPEs for occupational exposure, we talk about the term APF, not N95 or N97. APF is the assigned protection factor. The more the APF of a device, the better it is going to protect. And there are now devices, which are as high as APF 20,000. Your classic masks and all would be APF 4 and N95 would be an APF 4. However, there are very good masks and devices which are now available which go as high as APF 4,000, 20,000. 20,000 is the limit. So people who are really exposed to very large quanta should be given access to these kind of devices. So to summarize, pneumoconiosis, occupational asthma are very, very common in our country. They are something which are missed out in the histories of these patients. And for us, it is an absolute must as pulmonologists, as anyone who deals with respiratory patients or anyone who takes the respiratory history of the patients, please talk about their occupations. And it is not an absolute must that the patient will give you an history that, you know, they shifted their job in the last 1 year and they have developed this asthma. People who have been in the same occupation for 20 years, did not develop any respiratory disease, can develop a respiratory disease even after a very long latency period, right? Thank you very much for your patient hearing.